All right, so we did the nephron, right, which is your made out of the glomerulus and the glomerular capsule, and then we go through the peritubular capillaries. Let me see if I do this here. All right. So, and then we go to the proximal convoluted tubule. That one is called proximal because it's close to the glomerulus. Then we get to the loop of Henle, and loop of Henle is a whole separate area of the nephron where I mentioned last week, we're doing the concentration of the medulla. So if you notice, these tubules, they're all surrounded by capillaries, right? So peritubular capillaries, meaning capillaries around the tubules. And then we end up in the final portion, which is this distal convoluted tubule. Distal because it's away from the glomerulus, and convoluted because it's twisted. And then we end up in the collecting duct. And finally, at the end here is when we collect the urine. Now, I also mentioned that the several nephrons may share a collecting duct, so that all these nephrons are very close to each other. So one nephron has one glomerulus, but they can share the collecting duct. So on the other side, we could have another nephron that is also dumping into the collecting duct. So before we continue, I just want to make sure that you have this clear. So I'm going to do a little whiteboard here. And what I want to do is, let's keep the same colors. Oh my God, my lines. So these are the tubules, keeping the same colors. And then I'm gonna do red for, oh my God, for the vessels, peritubular capillaries. And so one thing that you should know is that when we bring the blood, we're gonna be doing filtration. So means from blood to the tubules. So that's the first step in urine. Then when we go to the distal and the loop of Henle, we do from tubule to blood, and that is reabsorption. And then at the end, in the distal, what you're going to do is secretion, which is the third step in urine formation. So if you notice, we're going between the tubule and the blood vessels many times. So in the first step, which is your filtration, obviously that happens in the glomerular capsule, right? We have these fenestrated capillaries. We are filtering with this force, which is your blood pressure coming in here. And we're filtering things. And in this first step of filtration, sometimes we get things in the capsule, in this lumen of the starting of the nephron, that they need to go back into blood. So that's why in the proximal convoluted tubule, we do a lot of reabsorption. So mostly what we reabsorb there are amino acids that we may need, glucose, water, anything else that we need in our blood. Sometimes they're filtered out, but the proximal convoluted has a simple cuboidal epithelium with a lot of microvilli, so that they're kind of like little hairs trying to reabsorb as much as possible that needs to go back into circulation. And then we get to the loop of Henle, which is mostly to reabsorb the rest of the water. So in order for us to reabsorb most of the water, remember we filter 180 liters a day, but we only make between 1 and 2 liters of urine. So it means that we have to reabsorb between 178 and 179 liters of water back into circulation. So that will happen right here in the loop of Henle. So if you notice, the actual loop is deep into the medulla of the kidney. So this is the medulla, and this lighter portion up here is the cortex. And so we are way deep into the medulla. And at the same time, you can see that we have a lot of these peritubular capillaries there. And so this is a process that is called the countercurrent multiplier. And we're going to go and analyze it, how that works. And then in the distal is where we do that secretion. We do secretion of hydrogen ions, illegal drugs, legal drugs, things that they need to be excreted out. So we're going to put them back from the blood into the distal. Now, at the end of the distal and beginning of the collecting, this is where the nephron makes kind of like the last check on water content in the body. So if there has been dehydration or bleeding, things like that, then we're going to have ADH having an effect here, and we're going to reabsorb even more water before we get things into the collecting duct. Because once they're here at this stage, that anything that is here is going to show up in urine. So we're clear on that, right? All right, so here is just a little picture of the fenestrated capillaries in the glomerulus. I told you that we only have 2 places in the body that we have this kind of endothelium, and this is where you have little openings between each of the smooth epithelium here, simple squamous epithelium. So they make these little pores, and so that it can act as a sieve. We also have fenestrated capillaries in the liver. So here is just to show you filtration and how, if you notice, the afferent arteriole has a larger diameter than the efferent. And so not only we are having the blood pressure coming in, which is going to be the force pushing things out, but we also create more pressure because the exit arteriole or the efferent arteriole is smaller, so that we can have a good filtration pressure right there in the glomerulus. And if you notice here, the green little dots here is albumin. So remember, albumin needs to stay in our blood vessels because it has to do with the osmotic or oncotic pressure of the blood. And that's what is going to help maintain most of the fluid, most of that plasma volume inside the capillaries. And so there are situations when the blood pressure here is too high, let's say for hypertensive patients. And so sometimes this protein is going to be forced out because the slits, the little pores between the simple squamous epithelium becomes a little enlarged, and that allows for larger molecules to be filtered out, which is not good and it's not normal, right? So normally we're just going to have things on the capsule that are supposed to go through in this first step. Some of these in the purple, they could be glucose, amino acids. Those are going to be reabsorbed immediately. So this is what we were talking about, that we have 180 liters a day. So it's about 45 gallons. That's a lot. And that means, with little math, that means the total volume is filtered, total volume of blood, which is 5 liters, is filtered every about 40 minutes. And most of it needs to be reabsorbed immediately because it has to do with our blood volume. You don't want to do anything here. So these are some of the sympathetic nerve effects. And Chris, if you're here, this was one of your questions. So if you have low blood pressure, obviously the low blood pressure is going to trigger the baroreceptor reflex. And remember, our receptors for blood pressure were in the aortic and carotid sinuses, right? So when you have low blood pressure, the compensatory mechanism is to increase sympathetic activity, which is going to increase ultimately blood pressure and blood volume. So this is what we learned on cardiac, right? Cardiac output is going to increase, which in turn is going to increase blood pressure, and that is going to help us increase blood volume. But when we talk about the kidneys, what are the kidneys doing when we have low blood pressure? The kidneys then, they're going to vasoconstrict the afferent arteriole, meaning that we're going to be filtering less blood per minute, and we're going to decrease the urine production because we are already dealing with low blood pressure, low blood volume. So what the kidney tries to do is to conserve whatever blood is there, right? So that's why when you have low blood pressure, the kidney is going to immediately compensate by producing less urine. So what happens is that the renal autoregulation means that the kidney, and autoregulation means the kidney does it on its own. It's such a wonderful organ that can detect things and can have those compensatory mechanisms. The kidney, even if the blood pressure changes or the amount of erythrocytes, the kidney needs to constantly keep a constant filtration rate, because if we change that, then we're going to be accumulating waste in our blood. And the kidney has its own autoregulation, which means it's innate from the kidney that even with changes in blood pressure, the kidney has to guarantee that we maintain a constant glomerular filtration rate, which means a certain amount of blood needs to be filtered per unit time. So if the pressure is less than 70, which that's a very low blood pressure, the afferent arteriole is going to vasodilate so we can get more blood in. The force is not as strong, but opening up the afferent is going to allow for more blood to come in, and that we can clean the blood or filter all the waste out of it. And the opposite, if the blood pressure is higher than normal, instead of keeping the same diameter, the afferent arteriole is going to close up a little bit so that we don't have tremendous force coming into the glomerulus and causing possibly that albumin is going to be filtered out, and other things that should stay in blood are not filtered out into the filter. So this is how we can regulate glomerular filtration rate. Remember, this refers to the amount of blood that we filter in the glomerulus per unit time, right? So if you have an activation of the baroreceptor reflex, which means baro means pressure, so this is from blood pressure dropping, the afferent arteriole is going to constrict, so we're not going to filter too much urine out because that's going to decrease the blood pressure even more. So that's why it says the GFR decreases. And if you have decreasing blood pressure, not because of a baroreflex, but just because the blood pressure reaching the glomerulus is not enough, then the autoregulation of the kidney is going to dilate the afferent arteriole so that we can get more blood in and we maintain normal GFR. And if there's increased blood pressure, it will constrict a little so that we can maintain the same GFR, so that we don't have any changes in how we're filtering the blood and getting rid of waste. So the next step is the one I mentioned, which is reabsorption. This is the beginning of the PCT, or proximal convoluted tubule. And this is where we do a lot of reabsorption: water, sodium, potassium, amino acids, glucose, anything that we know it needs to go back to blood and we need it in the body. So that's what the proximal convoluted tubule will do. And then we get to my favorite, countercurrent multiplier system. So once the proximal convoluted tubule has absorbed everything that needed, then we're going to go into the loop of Henle. So this loop of Henle has a descending limb, which is the first one here, descending. And then when it goes up, it has an ascending loop. Now, if you notice, the descending is skinnier than the ascending one. So it's a little thicker here. The other thing that these two sides of the loop are different in is that the descending is permeable to water. So you see here the little arrows where the water is coming from the tubule into the medulla, right? Then when you get to go up on the ascending, here is not permeable to water, but is permeable to salt. So we have two different permeabilities on each side of the loop. One is permeable to water on the descending. When we go ascending, it's permeable to salt. The other thing that I want you to know is this little number here, right? And see how the numbers change. So you start with 300 milliosmoles. So what is 300 milliosmoles? Is isotonic with the plasma. 300 milliosmoles equals 0.9% saline. So remember when we studied 0.9% saline, chapter 6, I think it was a long time ago. Can't believe that we're already toward the end, but I told you that when we were going to see urinary, you were going to see that we were talking about 300 milliosmoles instead of the 0.9%. So here is particularly important because remember that osmolarity measures osmotically active particles. Do you remember that? We said that one time ago. And what are osmotically active particles? It means that they're gonna, osmotically comes from osmosis, right? So the more osmotically active particles we have, the more water is gonna be drawn to it. So this is a concept that you have to remember from when we did osmosis and diffusion, right? And I also explained that salt, like sodium chloride, a molecule, really doesn't stay that way in our system, in our cells, in biological systems, right? Salt really becomes sodium ion and chloride ion. So that's why here you can see sodium positive, chloride negative. This is salt. But if you think about biological systems like our cells and our body, we don't really see the salt in the form of crystals, but we see it in the form of ions, right? So these two little sodium chloride ions are osmotically active particles. So the more we have of those, the more we're going to be drawing water to it. Is that clear? Is that a concept that you have down, Pat? All right. So if you look at the beginning, when this filtrate comes from the proximal convoluted tubule and is going to go into the descending loop, limb of the loop of Henle, we start with isotonic with plasma, 300 milliosmoles in the tubule, same as in the plasma. Now look what happens as we start going down into this descending. What's happening here? We started with 300 and we go 600, 800, 1,000, and 1,400 right here at the bottom of this loop, right? And why we have been concentrating this fluid here is because water is going out of the tubule into the medulla, and immediately that water is going to get reabsorbed into blood. Remember, we have to reabsorb at least 179 liters a day. So what we're doing in this countercurrent multiplier is we're concentrating the medulla so we can draw water out of the tubules, and that water then can go into the blood. So when you get to the ascending, look what happens to the concentration. It's very high here, 1400 milliosmoles. As we go up, we are trying to make this fluid very, very dilute, 100, right? So this is hypotonic considering the comparison with plasma, right? Plasma is 300, but we're trying to make a more dilute urine. Remember, we only want to get rid of things that are waste, but not a bunch of stuff. We don't want to get rid of a bunch of stuff in the urine. So our urine in general and normally is a diluted urine. It has a lot more water than dissolved things in it because we like to reabsorb everything that we need, right? Now, why we are diluting here is because on this ascending limb, salt starts to diffuse out of the tube and it gets into the medulla. So you see a bunch of salt here, right? So the medulla, the tissue, is very, very hypertonic, yes? So the more salt we draw out from the tubule here into the medulla, the more water comes out on this descending end. And what you have to think is that this is going on at all times, right? So down, up, so many times. That's what it's called multiplier, because it's so many times that we do this little pathway of coming down the descending, up the ascending. Why do we call it countercurrent? Because on one side, the descending limb comes down, the fluid, and on the other side, in the ascending limb, the fluid goes up. So that's what the name comes from, countercurrent. They're going in opposite direction. I need the student here. They're going in opposite direction. What's happening in the ascending is that a lot of salt comes out, and by the time the descending comes in, because there's a lot of salt in the medulla already from the ascending, the water starts to come out because it's going to try to go dissolve that salt. We are making the medulla hypertonic so that when the fluid comes down the descending, water finds that this medulla is hypertonic and it starts to being drawn to this medulla, and that water immediately is reabsorbed into blood. So the countercurrent multiplier is doing two things. It's concentrating the medulla so that we can draw the most water out of the loop of Henle into blood, and it's also making dilute urine. So is that clear what we do here in the countercurrent multiplier? So it's not happening at the same time. So the liquid that comes down the descending is already finding the hyperconcentrated medulla, because on this side we've been excreting the salt. And that's why by the time we come down here, this salt is already here from the last cycle going up, right? So the more times this happens, the more salt I accumulate here. And by the time I come down here, more water I'm going to be taking out, and I'm going to be putting that all the way back into the blood. This is just to maintain our blood volume and to reabsorb the most water possible. All right, so here is what's happening in what is called the vasa recta. The vasa recta is just the peritubular capillaries that they are around the loop of Henle. So that's why it has this shape. And if you notice here, you have that change in the milliosmoles. We start isotonic. We get down to a concentrated area here, but by the time we go up, we are trying to get a more hypotonic environment. So we mentioned that urea is the main component in urine, okay? So that's why urine is called urine, because urea is nitrogenous waste, right? So this is where we digest proteins, and the amino portion or any molecule that we are digesting that has nitrogen, we have to eliminate that. Nitrogen is a bad waste for us. We don't really utilize any nitrogen. So all this nitrogenous waste becomes what is called urea. So think about urea kind of like ammonia, which is very bad for us, for humans, right? So we have to get rid of urea, but there's also a little bit of reabsorption of urea that we have. So at any time, we're going to have a lot of urea showing up in urine, but we're going to have a little bit in blood as well, because you can see that we reabsorb a little bit of urea. So when your kidneys are not working, we're not going to be able to get rid of that urea through urine. And what happens is it starts to increase in blood, and that condition is called uremia, which is very serious. It totally takes our organs into shock, and people can die from uremia. So people with acute renal failure, and that is when your kidneys stop working, they die from uremia. It's almost like having a very toxic amount in blood, and that starts to affect and shock different organs in the body. And that's why when people say it was a organ failure, that's when every single organ will start to fail, mostly heart, lungs, and kidneys. All right, so we mentioned that ADH works on the distal convoluted tubule, and ADH, what it does is that it creates water channels, which are called aquaporins. So if we have low blood volume due to a hemorrhage, bleeding, or dehydration, ADH is going to be secreted from the posterior pituitary, and it's going to go to that distal tubule, and it's going to start putting these little channels, aquaporins or water channels, so that water can be reabsorbed right there before it gets to the collecting duct, because anything that gets in the collecting duct, remember, is going to show up in urine. So that's how ADH works. So this, you probably remember this from endocrine system. And you have two different situations here in how ADH will work. So we have the stimulus of low water intake. You have to the left, it says dehydration. So you know that dehydration, losing water from blood plasma, is gonna increase the osmolarity of the plasma, right? The plasma is gonna be more concentrated if we have less water. So we have osmoreceptors. Osmo meaning they're checking the osmolarity of the plasma. And when the plasma osmolarity is increased, which I think you can see the little arrows there. There you go. And in this one, you can't see it either. That's a little better, right? So when the plasma osmolarity increases, means that we have low blood volume, low plasma. So the osmoreceptors in the hypothalamus are going to detect that, and they're going to send the information to secrete the ADH. And that's how posterior pituitary secretes ADH, and it's going to tell the kidneys to reabsorb more water. So we're going to make less urine. That will be the compensatory mechanism, right? If we have the other situation on the right, where we have overhydration, so your plasma osmolality is going to be lowered. You're going to have a lot more water than the dissolved particles. Then we're not going to secrete any ADH, and we're going to make more urine, and that's how we correct the situation. And these little arrows, they're not even, you can't even see that. There you go. I don't know why you can see that. There we go. So if you are overhydrated, obviously you're gonna excrete more urine because you wanna keep the plasma osmolality at 300 milliosmoles, which is isotonic, right? Inside, outside of our cells. We want always to keep that isotonicity. Okay, we talk about secretion. Secretion is the reverse of the reabsorption. In secretion is when we're putting things from the blood back into the tubules. That's our last part in making urine. And again, here the kidney will make like a double check. For example, if the blood is too acidic, if the pH is changing, we're gonna secrete hydrogen ions from blood back into the tubule to make sure that our blood pH is kept within normal range. Any antibiotics, any excess vitamins that you take, especially the soluble vitamins, we're gonna secrete all that from the blood into the distal so that we can excrete those out. And of course, illegal drugs, that's why you do drug testing in urine, because any metabolites of illegal drugs or legal drugs are going to be secreted out and they're going to be eliminated with our urine. All right, so I'm going to stop for about 10 minutes because we've been going for an hour, and we'll be back at 2:17. And let me stop. All right, so there are several tests that determine the health of the kidney and how the urinary system is working. So one of them is called the clearance of inulin. Inulin is a chemical that is found in certain foods like garlic, onions, artichokes, dahlias. So it's a measurement of glomerular filtration rate. Remember that GFR is an indication of how well something is being cleared from the blood by the kidney. So inulin is good to check because it's something that is natural and is not reabsorbed or secreted, meaning that if it's filtered, it's just gonna show up in urine. So the little formula is the GFR equals the rate of urine formation, how much urine we're making per unit time, the concentration of inulin in the urine, and the concentration of inulin in the plasma. So what they do is they will collect urine for a specific amount of time, which is usually 24 hours. When the patient comes, they check the concentration in plasma, and then they analyze the concentration of that solution of inulin in the urine. And like that, they get the glomerular filtration rate for a particular chemical. And this is kind of like showing what happens to inulin. Is filtered here in the glomerulus, and then it's going to be eliminated in the urine, and we're also going to determine the levels in the blood. So like that, knowing a base amount in blood and then determining how much shows up in the urine, it gives the doctor a good idea of glomerular filtration rate, how fast something that is in blood is going to show up in urine. So that's one test that sometimes is done. The other one is the clearance. Clearance means filtering it out from the blood to the urine of this para-aminohippuric acid, or PAH. So this is something that is exogenous, which means it's not natural and occurring in our blood. So this is something that needs to be injected into blood, is not reabsorbed. So let's say that you inject 100 mLs. When you check the urine, then you should be able to recover 100 mLs of this PAH. This is not that common. We don't do this one because it's injecting something exogenous in a patient. So this is one other test to check for GFR, but it's not commonly used just because in general, we don't like to inject things into a patient that is not natural. And again, you start with a specific concentration, you check the concentration in blood right after, and then you collect the urine and you check the concentration in urine. The other things that we've already learned a little bit about this, but now we see exactly what is happening. Remember when we studied the RAS system and how the kidneys are able to detect low blood pressure or low concentration of erythrocytes. So where is that happening? So it happens in what is called the juxtaglomerular apparatus. So the juxtaglomerular apparatus is a combination of cells that is right where the afferent arteriole comes into contact with the distal tubule. So when you go back to looking at the nephron, the way that we look at it to study it is not really true. So here we're seeing that the nephron in kind of like a flat one dimension, right? So you have the glomerulus, the proximal, loop of Henle, distal. In real life, the glomerulus and the distal, they're touching. So the distal, that's kind of like a fold and it touches the afferent arteriole, kind of like from the back. So this picture that you are seeing right now is how we studied the nephron, right? But it's in one dimension, flat. In real life, know that the afferent arteriole of the glomerulus touches the distal convoluted tubule from the back. So that's what the juxtaglomerular apparatus is. It's a group of cells in that particular region of the afferent arteriole touching the distal. Okay, so when you look at it in a large picture, this is the afferent. This is the, did I say the distal? It's the loop of Henle, sorry. The loop of Henle, the ascending loop of Henle. So if you look at these cells here that says granular cells, those cells plus the tubule cells, that's what they call juxtaglomerular apparatus. So the nephron is twisted, right? It's folded onto itself. So these are the cells of the juxtaglomerular apparatus that they detect low erythrocyte content and they detect low blood pressure, which in turn is going to activate the RAS. So if you look at this outline here, when you have low sodium intake, so you have not a lot of salt here, right? So you have low sodium concentration, you have low sodium in plasma. And remember, sodium goes with chloride and with what else? Sodium chloride and?
Water.
Water, right? So when you have low plasma concentration of sodium here, low plasma sodium concentration, that means that you have low blood volume because there's not salt, you have not a lot of water. So that triggers the posterior pituitary to increase the water reabsorption. And like that, we're going to, wait a minute. See, this one doesn't make sense. Okay. So, oops. I always do this when I'm not in. I think that's it. Okay. So low sodium intake, it means we're not taking a lot of sodium. So in this particular case, we are decreasing ADH. This is the problem, right? This is the stimulus. We are not having ADH, so we're making a lot of urine. That in turn, if you get rid of a lot of urine, you're going to decrease the blood volume. So if we have low blood volume, the correction or the compensatory mechanism is for the juxtaglomerular apparatus to detect that blood volume that is low, and the kidney secretes renin. And this is what starts the RAS. So renin then goes to the lungs, and remember that we do angiotensin 1 to angiotensin 2. Angiotensin 2 then goes to the adrenal cortex, secretes aldosterone, and aldosterone is going to increase sodium reabsorption, which in turn is going to increase water reabsorption, and that increases the blood pressure. So those little cells of the juxtaglomerular apparatus are the ones that are detecting the drop in blood volume, and they are the ones that start or initiate RAS, because it starts with renin being secreted from the kidney. We learned this when we did endocrine, but now you know exactly which are the little cells that have those sensors to detect the low blood volume. The other hormone that we learned in endocrine was the atrial natriuretic peptide. So atrial natriuretic peptide is the one that is secreted when we have an increase in blood volume, because there's a stretching of the atria, right? If you have a lot of blood volume, the atria of the heart is going to stretch beyond normal, and that's what's going to trigger the secretion of this ANP. So ANP is going to tell the kidneys to get rid of salt, therefore water, and that controls the increase in blood pressure. So this is the opposite of RAS, right? RAS is when blood pressure is low. Atrial natriuretic peptide is when blood pressure is high. So we have to get rid of some water, and that is through getting rid of sodium. All right. Other things that the kidney can do is to play with the reabsorption of bicarbonate and reabsorption of hydrogen ions. And so it has to do with your pH, right? If you have problems in your respiratory system, for example, alkalosis, so you don't have a lot of hydrogen ions in the tubules. So if you have alkalosis, what you want to do is get rid of bicarbonate, so that you're going to secrete bicarbonate in the tubule, and you're going to make a more alkaline urine, so that we can keep the pH of the blood within normal range. Remember that alkalosis will be above 745. So if that's the case, it means that we need to reabsorb hydrogen ions and excrete bicarbonate. And the other way around is also true if we have a lot of acidity in the blood. We have to reabsorb bicarbonate and get rid of the hydrogen ions. We'll be secreting hydrogen ions out into the urine. I'm sure that you've all heard about diuretics, and I'm not going to ask you the name of the diuretics and what they do, but they each work in different parts of the nephron. So you can see here, there's diuretics that are carbonic anhydrase inhibitors, so that they're going to block the reabsorption of sodium, so the patient is going to make more urine. You also have some loop diuretics. Here, they're going to block again the salt coming into the medulla, so more water is going to be secreted out. Then you have the diazide diuretics, and you also have potassium sparing diuretics. What they're doing is playing with the salt concentration, and that allows for more salt and more water to be excreted out. Most cardiac patients will take diuretics because that maintains their blood volume at certain levels, which in turn controls the blood pressure. And as you know, a lot of the cardiac patients they can't eat salty foods. They are restricted in their diet of massive intakes of salt. Because remember, salt takes water in, so that will increase even more their blood pressure. All right, so we've studied, well, we've learned about the para-aminohippuric acid inulin clearance. Remember, the clearance, renal clearance means taking something from the blood and making sure that it appears in the urine. So we can detect what is called nephritis. So nephritis is an inflammation of the nephron. So it could be nephritis, inflammation, or infection, right? Anything ending in itis, that's what it means. We can also find albumin in urine, and we did this in one of our, I think, that discussion boards. You can detect some type of protein in the urine. It could be an indication of renal damage. Mostly the pores of the fenestrated capillaries in the glomerulus are larger than normal. In some cases is diabetes. When you have proteinuria, which is large amounts of proteins, that's a little more serious. That means that many nephrons are affected, and that can overtake the kidney, the whole kidney. So kidney diseases, acute renal failure is when all of a sudden something happens to the kidneys and they stop urine formation. They cannot detect, they cannot regulate blood volume, pH, and this happens in a matter of hours or just days. That's why it's called acute. Acute means something that comes all of a sudden. And it could happen from using too many NSAIDs, those Advil, ibuprofen drugs, atherosclerosis of the renal arteries. So atherosclerosis is the accumulation of fat deposits so that the blood flow is not going the right way in the kidneys, or inflammation of the renal tubules for infection or something like that. I mean, an acute infection can lead to an acute renal failure. Glomerulonephritis is the inflammation of the glomerulus. Remember, the glomerulus is the ball of capillaries, right? And so many times is antibodies that are produced due to streptococcus infection. And it could be streptococcus from the throat that has reached the kidneys and is affecting the glomerulus. What happens is anything that happens to those little capillaries is going to open up those pores. And that's when you start seeing a lot of protein in the urine. That leads obviously to a decreased osmotic pressure of the blood and ultimately edema, right? Remember, albumin needs to stay inside the blood vessel so that we can keep all the water volume in there, and edema will be that liquid accumulating in the tissues around. Renal insufficiency is any activity of the renal, or any decrease of renal activity. So it could be for many reasons: infections, inflammation, diabetes, patients that are constantly filtering massive amounts of glucose. It damages the glomerulus. And also could be because of blockage with kidney stones, which are really, really painful. They said that it's almost like giving birth with no anesthetic. So when males get kidney stones, then they know what labor pains are all about. Very, very painful. When your kidneys don't work, obviously you end up with high blood pressure, high acidosis, high hydrogen ions, uremia, which is very, very serious. And you can see there the patients with the uremia, which is the increase of urea in the blood. At the end, they have to be placed on dialysis, and what's coming there. And dialysis, of course, you all know that is the artificial kidney, is when the blood is transferred through a machine that it does the kidney work, it clears it all up, and then it comes back into the patient. And if you know anything about dialysis, it's a very involved procedure. It takes many hours. You know that we are filtering 180 liters of blood a day. So it takes a while to filter all our blood 40 times in one day. So this could make a patient not able to work or have a very normal life. There's this ambulatory peritoneal dialysis, which is where the patient does it at home, and it has a little machine that is doing the dialysis through the abdominal cavity. It's not as efficient, and some patients that start with that one, they have to end up with the typical dialysis at a dialysis lab. And that's about it for kidneys. Any questions on the kidney? Save, I made so many changes here. No questions there? We're good? All right, so in order to be on schedule, I'm gonna talk a little bit about digestive systems, since that's what we're looking at this week. Digestive, I think, is easier than the chapters that we've been talking about, like cardiac, respiratory, and urinary. Those are the most involved ones. So chapter 18 is our digestive system. I'll try to do this. So we talked a little bit about our nutrients when we talked about the lab, the virtual labs that we're doing this week. So digestion means breaking down food with the help of water. So that's why it says hydrolysis reactions. Hydrolysis is breaking down with the addition of water. So the first reaction that we have here is maltose. So it's a disaccharide. When we add water and a particular and specific enzyme, we're going to break it down into 2 molecules of glucose. So we go from a disaccharide to a monosaccharide. So when we ingest food in the form of carbohydrates, we're going to break it down, hopefully, all the way to monosaccharides, because the monosaccharides are the ones that our cells can utilize, especially for cellular respiration. When we ingest proteins, like in this case, and we add water and a particular enzyme, then we're going to break it down into amino acids. And we utilize these amino acids to create other proteins that we may need. When we eat fats, and here you have a lipid, and this is a molecule of glycerol and 3 fatty acids on the left. When you add water to it and a specific lipase or digesting enzyme, you're going to be breaking them down into glycerol and fatty acids. Again, the fatty acids is what we like to use for energy when we don't have any glucose present, for example. So what do we do in our digestive tract? Well, we do a lot of motility, right? How do we move things through the digestive tract? So we call the digestive tract also the GI tract or gastrointestinal tract. It's one tube that has connections with the external environment on both ends. And it's the only system that does that, right? So we start in the mouth, taking the food in the mouth. We then do mastication, which is chewing. We, in the oral cavity, we mix the food with saliva. And then whenever we think it's ready, there's a conscious activity that we decide to swallow, which is deglutition. And then once the food gets into our intestines, we have two types of movements. One is peristalsis, which is wave-like movement along the tract. And the other one is segmentation, which is mixing and moving forward, not in the form of a wave. So it's a little different. But they're all mixing movements that we have to do. First to mix it with saliva, then with all the digestive enzymes. We also have a lot of enzymes, and these enzymes are secreted through ducts. So they are exocrine secretions, right? Exocrine is anything that you secrete into a lumen of an organ through a tube, right? Or a duct. But we also have some endocrine hormones that are involved in digestion. So think about when we learn about endocrine system, we mentioned that the gland makes the hormone, secretes it into blood, and then from there, it can be taken to the target organs. Well, with the digestive hormones is a little different because cells in a specific organ are considered the endocrine cells. They will secrete that hormone into blood, and it's going to go through the whole circulatory system and come back to the same organ. But they are still considered endocrine hormones, right? But they're just specific for digestion. And of course, we have to do digestion, which is to break down foods to the smallest units. And the smallest are the monosaccharides, the amino acids, the fatty acids, and the nucleic acids need to be broken down into nucleotides. So everything needs to be digested or broken down all the way to their smallest units. And then what we have to do with those smallest units, we have to absorb them into blood or lymph. We're going to learn that carbohydrates, amino acids, and nucleotides are absorbed directly into blood, but fats are absorbed into the lymph, and then at the end, they are put together in blood with the other nutrients. At the end of this digestion and absorption, we also have storage and elimination. So storage is the temporary storage of feces, mostly in the rectum, and then the elimination is the defecation act. Hold on one second. Okay. If you, I don't remember, some of you I think took 201, but if you did, you probably remember that within the intestines, we have a lot of simple columnar cells. It's a simple columnar epithelium, and it's very, these cells are in the epithelial tissues are very close to each other, so there's no space in between the cells, which makes it highly, highly protective. But also in the mucosa of the digestive tract or GI tract, there's a lot of lymphocytes. And these lymphocytes are there in groups or patches, we're gonna see in different areas, which are there for protection. So we don't eat sterilized food. So we need that protection. Maybe a little bacteria came in with food, and you don't want to put that into blood. So it will be taken care of right there in the mucosa or submucosa of the digestive tract. So these are the organs of the digestive system. So we start with the oral cavity. The oral cavity has the teeth, the palate, and also the salivary glands. So between those is that we can do the mastication, chewing, breaking down our food. The salivary glands will secrete saliva, so we can mix our food with the saliva. And then between the tongue and the palate, we start to push things up, and we make what is called the bolus, B-O-L-U-S. The bolus is the first step before swallowing. So it's when we mix our nutrients with saliva. So then after that, we do the swallowing reflex. And remember that we mentioned this in respiratory, that when we swallow, the epiglottis closes the glottis, which is the entrance to the trachea, so that we can push the bolus back or behind. Because we have the trachea is in the front, the esophagus is posterior to it, but they're very close to each other. So the epiglottis, remember, was that little cartilage that will close the entrance to the trachea, and the food then is pushed back into the esophagus. So the esophagus is this one right here. This is a long tube that pierces the diaphragm and it gets into the stomach. So the stomach, I like to call it like a washing machine. The stomach, when you get food into the stomach will secrete some gastric juice, and we're gonna see what that is, but to start is very acidic pH. We also have pepsin in the stomach, which is the enzyme to start breaking proteins down. And we have other hormones here, but what happens is when the food gets to the stomach and is mixed with all those gastric juices, then the food content is called chyme. Chyme, C-H-Y-M-E, chyme. So when it comes down, the food comes down mostly to this region here, lower of the stomach, but because the stomach has 3 layers of muscle, it acts pretty much like a washing machine. So food comes down, and then those 3 layers of muscle will push it up, and from up comes down again, and it goes this way. So the chyme is mixed with all these gastric juices, and it becomes liquid, right? The bolus is solid when it gets to the stomach and it starts to mix with all these movements and all the gastric juices. The chyme then is liquid. So the carbohydrate digestion starts in the oral cavity with salivary amylase. Comes into the stomach, salivary amylase goes inactive because the pH in the stomach is very acidic. But we have pepsin in the stomach where we start then the digestion of proteins. So we don't finish it there, but it starts there. So proteins may be cut to polypeptides, maybe 30, 40 amino acids. We start shortening the big protein, but we don't finish the digestion of proteins there. So once we are ready, the chyme then enters the duodenum, which is this first portion of the small intestine. And here is where we get all the secretions from the pancreas. So pancreas and liver with the gallbladder, they're accessory organs of the digestive system. They're not part of the digestive system, but they're helping digestion, right? We also know that the pancreas is an endocrine gland as well. So the exocrine portion of the pancreas, you see there's little green ducts. Those ducts are collecting the pancreatic juice, and all that pancreatic juice gets into the duodenum. So in the duodenum, the pH changes back to basic because the pancreatic juice has a lot of bicarbonate and it makes the environment more alkaline, more basic. So we're going to see a bunch of enzymes that come from the pancreas. And in the duodenum is when we do most of the digestion, meaning we're going to finish up digestion of carbohydrates, we're going to finish up digestion of proteins, of nucleic acids, and fats. So once that we have all that digested, then we're going to go through the rest of the small intestine, and we're going to do a lot of absorption. And the absorption happens when we have completed digestion, and we can then take all these nutrients in the smallest subunits into blood. Now in here, we have to talk about the digestion of fats, right? Digestion of fats happen into lymph first, and then they're going to join the carbohydrates, the proteins, and the nucleic acids. Once we have reabsorbed here a lot of the nutrients and water, again, because you don't want to have a lot of water content here, then we go through the first portion of the large intestine or colon, which is called the cecum. You can see here from the cecum, we have this projection that is the appendix. Now, the appendix has a lot of lymphoid tissue, so lymphocytes, a lot of kind of like immune tissue, right? So the appendix is really there to fight infection, so to make sure that we're not taking like a bunch of bacteria with our food. But a lot of times the appendix gets infected itself. And that's when, if it gets infected, you're going to get a swollen appendix, and it's going to be inflamed, and it's going to cause pain. And because it's not really useful if it's infected, then you have to have appendectomy. So they would just cut it, and you really don't need it, right, when it gets infected. And it could cause serious issues as well. If it's infected and inflamed, it gets swollen, and if you don't take care of it, the appendix can burst, and then it causes peritonitis, which means that the whole region here that is surrounded by membranes called the peritoneum, they're all going to get infected and inflamed. And that's very serious. That requires emergency surgery. Obviously, they have to take that appendix that has burst out of the body, but also what they have to do is they have to clean all these organs, mostly the intestines, that have been bathed with all these bacteria. So literally what they have to do is take the intestines out, they have to hose them down with antibiotic solution and then push them back in. So peritonitis is a serious infection, and the surgery is not fun, right? Imagine how you feel after that surgery when they take these organs out and they put them all back in. Okay, so then we go from the cecum, we go to the ascending colon, which is on the right side of the body, ascending colon. Then the colon crosses across to the other side of the body, and that's why it's called the transverse, large intestine or colon, same thing. And then it goes descending on the left side of the body. And then we have the sigmoid, which is this last little curve here, the rectum and the anal canal. So what are we doing in the colon is we are reabsorbing mostly water, because if you don't reabsorb the water, that's when you get diarrhea, right? Loose stools, which is not good either, right? You don't want to lose water because that causes dehydration. And now you can start thinking what your heart is going to do, what your kidneys are going to do, right? So diarrhea can also lead to dehydration. So the colon mostly is reabsorbing water, vitamins, and we have that healthy bacteria that we have in the colon, which it processes vitamins for us, and we can reabsorb those. And then whatever solid waste, we're gonna pack it in the rectum. And when we have feces in the rectum, that stimulates the anal sphincters. So the sphincters in the anus are very similar to the sphincters in the urethra. So we have two, one internal, one external. So the internal is a little higher up and is made out of smooth muscle, circular smooth muscle. The external anal sphincter is circular, but is skeletal muscle. So when the feces are in the rectum, they're going to start stimulating the internal sphincter. But we can hold it when you don't wear diapers. You can hold it because the external is skeletal and is voluntary. So we can hold it until you find a bathroom, right? With babies, the fact that they need diapers is because that external sphincter in the urethra and the anus is not fully developed, and that's why they need diapers. Once they start growing and developing, then they can hold it, and then they're toilet trained, right? And then maybe sometimes when we're old, we go back to wearing diapers again. And that is because the skeletal muscle is not as strong as it used to be. So the layers of the digestive system, the whole GI tract, this tube, right, has a lumen, so the light, and that's where the food goes, right? So the lumen is epithelium. And the epithelium changes depending if it's the oral cavity or if it's the stomach or the intestines, right? It goes kind of like changing. Then if we go out toward the outside of this GI tract, we have the submucosa. So the submucosa here, it will be this region over here. And that is, has a lot of blood vessels, it's connective tissue, it has glands, it has lymph nodes. Remember those lymphocytes that I was talking about? It has nerves. So the submucosa is, it has a bunch of stuff. So you see the blood vessels here, you see the lymph nodes, you see the nerves. And then going even more in this GI tract, we have the muscle layer. So most of the GI tract has two muscle layers. One is circular, meaning that it goes around. Just think about a hose, right? So these fibers go around, and these are smooth muscle, of course. And then the outermost is longitudinal. So if you think about a hose, the fibers are gonna run lengthwise. And the outermost layer of the GI tract is called the serosa. Serosa is just white fibrous connective tissue. And that white fibrous connective tissue becomes what we call the mesentery. So you can see here up in this picture, the mesentery. And this is important. We're going to learn this when we do the portal system, because the mesentery, as you see here, is has a lot of fat. It has a lot of blood vessels, arteries and veins, right? And the mesentery is that fiber that connects the intestines. So again, if you did 201, which is the anatomy, and you saw the cat or pictures, if you pull the intestines up, especially the small intestine, is that fiber, that membrane that connects the intestine. That's what the mesentery is. And it has a lot of vessels, arteries, and veins. So something that you have to remember. Now, one thing in the muscle layer, most of the GI tract has two layers, the circular and the longitudinal. The stomach, remember I said it has three layers. It has a oblique layer, an additional layer, which is what makes the stomach like a churning machine, like moving and mixing things very well. So this is what peristalsis looks like, and this is in the esophagus. So it's the wave-like contraction of those muscle layers that they are going to be pushing food down. And this is an example of the bolus, which is the mixture of food and saliva getting into the stomach. And this picture shows you the three layers of muscle that we have in the stomach. So we have the circular, the longitudinal, but we also add an oblique one, which is what makes this organ such a powerful organ in mixing the bolus with the gastric juices. And then we're going to have what we call chyme. So the stomach has different regions here. You can see that the one closest to, I would say, the heart, because it's on top, right? It's called the cardia of the stomach. Then the top rounded portion is called the fundus. Then we have the body. And toward the end, when we connect to the duodenum, we're going to have the pyloric region. And it's called pyloric because there's a sphincter here, pyloric sphincter, which will open up when the chyme is ready to go into the duodenum. When we have the food here mixing in the stomach, the pyloric sphincter is closed. We want to make sure that everything here is mixed. Once this is ready, then the pyloric sphincter will open up, and that's when the chyme gets into the duodenum. So I'm going to go and show you the picture here, because the stomach is has a lot of folds in the mucosa, which is called the rugae. And within, oh my God, I hate to do this. Within these folds, we have glands. So these folds at the bottom here is what we call gastric glands. And these gastric glands secrete the pepsinogen and the hydrochloric acid, okay? So the parietal cells secrete hydrochloric acid and intrinsic factor. Remember, intrinsic factor help us absorb vitamin B12, which is necessary to make red blood cells. So if you don't have an intrinsic factor, which is a little protein or part of the protein, we have pernicious anemia, right? And then the chief cells secrete pepsinogen. So pepsinogen is the inactive form of pepsin. So when we have these parietal cells secrete the hydrochloric acid, they're gonna change pepsinogen that comes from the chief cells into pepsin. So this is the first enzyme that is gonna start the first digestion of proteins. Stop moving these things. So here we come to the endocrine hormones that we start seeing in the digestive system. So the first one is called gastrin. This is a hormone that stimulates the ECL cells, and they're going to make histamine. Now remember, histamine is vasodilator. So we need a lot of blood rushing to the stomach so that we can mix all the food with this gastrin. So the gastrin, it's the hormone that is secreted by the stomach, has to get in blood, and it comes back to the stomach. So how do we activate pepsin? So the cells in the gastric gland are going to secrete the inactive form, which is pepsinogen. And then with the help of hydrochloric acid, we're going to make pepsin. Now, pepsin is a very powerful enzyme that will start the digestion of proteins. And I say start because it's not going to go all the way to amino acids, but it's going to go to short peptides. Remember, we finish digestion in the small intestine, in the duodenum, because we need the pancreatic enzymes. So there's only two things that we absorb in the stomach, alcohol and aspirin. So these are the only substances. That's why they say you can get drunk on an empty stomach, because you're not slowing down the absorption of the alcohol. It just goes straight into blood, right? So starches, we start to digest in the oral cavity, and that salivary amylase will get inactivated by the time it gets to the stomach, which is at about pH 2. And we don't absorb anything except alcohol and aspirin, but we start the digestion of proteins in the stomach. Now, there are some people that suffer from peptic ulcers, And this is where the mucosa of the stomach is eroded, and it can actually form like the cells are breaking, right? So it's very, very painful. So long time ago, we used to believe that ulcers was because the stomach was secreting excessive amounts of hydrochloric acid. And in general, our stomach is protected by a layer of mucus so that we don't digest our own cells in the stomach. But lately, long time ago, actually, there's a bacteria that is known to cause these peptic ulcers. And ulcers are now treated with antibiotics because they have to treat that Helicobacter pylori, which is the bacteria that causes a reduction of that protective mucus layer. And then the acid then can erode the mucosa and cause these ulcers and the pain. Acute gastritis, inflammation of the mucosa and the submucosa. And remember, anytime there's an inflammation, we increase the secretion of histamine, and histamine causes more acid release. So it kind of like be like a cyclic effect. And obviously people that suffer from gastritis, you get antacids so that you can inhibit histamine receptors so that we don't increase the acid secretion. Normal, typical Tagamet or Santac, those are the antacids. There's also duodenal ulcers, and these are the ones in the duodenum, right? And again, we have a protective layer of mucus in the duodenum, and that is very protective because we secrete bicarbonate in the duodenum. And obviously when the chyme comes in from the stomach, which is very acidic, it could cause some erosion of the mucosa of the duodenum. So then we go to the small intestine. Sorry, where am I? Here. So the typical anatomy of the small intestine is that the mucosa is folded, right, in many, many folds. And then each of the cells of the simple columnar cells, they have what they're called microvilli. So we have these big folds, which is called the villus, villi for many. And then each of the simple columnar cells have microvilli. So the small intestine has an extensive surface area because we're absorbing here. So we need that. So the villus is the big finger-like, the microvilli, the little hair or folds on the simple columnar cells. And so that increases the surface area for absorption. Also here in the submucosa, you still see the blood vessels, you see nerves, and you see this lymphoid tissue, which in the intestines are called patches because you have this lymphoid tissue, again, for protection. And you have your muscle layer and your serosa. And remember, the serosa is a continuation with the mesentery here. And why we do them in yellow? Because the mesentery attracts a lot of fat. So the small intestine, we already mentioned that it absorbs our nutrients, right? Carbohydrates, proteins, fats. We also absorb bile salts, vitamins, water. And because of the villi and the microvilli, it happens very fast because that gives a very large surface area. So when you look at one villus, like this, one finger-like projection. And if you notice here where you see simple columnar epithelium, each tiny little purple dot here is a simple columnar cell. And each cell has the microvilli. So that's why we have such a good surface area for absorption. The other thing that you should notice here is that in each of these villi, we have extensive capillary bed. So you see the arterioles, the venules, and the capillaries in the middle. That's when we're gonna absorb our nutrients. And then each of these villi has a lacteal, which is this yellow vessel here. It's called the lacteal. And that is a lymph duct, a lymph vessel. So remember that I mentioned before that fats don't go straight into blood, but they go first into lymph. So here in this lacteal is where we absorb the fats. And carbohydrates and proteins, we absorb them directly into blood. One more very important factor is that, and here you're looking at the lumen of the small intestine, so your nutrients are here, right? In the small intestine, specifically in the duodenum, we are finishing up the digestion of foods, meaning that we're taking them all the way to the monomeres, the smallest subunit. Well, sometimes what happens is that when we get to the small intestine and we have to start absorbing the nutrients, some nutrients are still in disaccharides or very short peptides. So what happens is that before we can absorb them, while they're passing through the simple columnar cell, they're going to go through these brush border enzymes. These enzymes are called brush border because they are on the epithelium, and the epithelium looks like a brush because it has all these microvilli. So these enzymes are not secreted into the lumen, but they're fixed on the membranes. And as the nutrients are being absorbed, they go through the brush border enzyme. And by the time they get here, where the blood vessels are, they're going to be converted into the monomeres, the smallest subunit. So if we didn't finish all the digestion in the duodenum, when we start absorbing some that are in the disaccharide or in a little larger proteins that they're not all the way into amino acids, they're going to go through the brush border enzymes and they're finally going to become the monomeres. So you can see here what are the brush border enzymes that we have. So the name is on the first column. Notice the ending ASE. Anything that ends in ASE is an enzyme. So these are disaccharidase. So we have a sucrase. Sucrase breaks down sucrose. Maltase breaks down maltose. And lactase breaks down lactose. So what is sucrose? Sucrose is table sugar and is made out of glucose and fructose. So it's a disaccharide. Maltase is the enzyme that breaks down maltose, which is beer sugar, which is made out of two glucose together. And lactase is milk sugar, the sugar that we find in milk. And that one breaks down lactose, which is made out of glucose and galactose. So if we didn't break them down all the way in the duodenum, the brush border enzymes are going to take care of it. Then we have peptidase, and these are breaking proteins that are still 2, 3, 4 amino acids long. And we also have phosphatases that they're going to help with the reabsorption of calcium, magnesium from the lumen into our blood. Remember, calcium, we needed to absorb vitamin D, right? So here you see the brush border enzymes, and you have all the villi here, and you see how from in the mucosa, we have all these capillaries and the lacteal that is gonna help us absorb the fat. And I'm gonna break for 10 more minutes, and we're gonna finish whatever we can with digestion. All right, so the last 30 minutes, let's see what we can cover. The other movement that we have in mostly the intestines is segmentation. So we not only have peristalsis, which is the wave-like pushing things with the contraction of the muscle layers, but we also have segmentation, which is more of a horizontal type of movement, and is pushing things in a straightforward manner. So we have a lot of segmentation in the colon, for example. And talking about the colon, this is the large intestine. We already went through the different portions of the colon. And as the small intestine, we also have this little layer of tissue here, which are part of the mesentery. The small intestine should be in all this central region here, okay? So as I mentioned before, functions of the colon is absorption of water, mostly by vitamins K, some B. Our vitamin K is vitamins in the colon are made by some of the good flora, intestinal flora, which are our good bacteria, like people knows it as. And then obviously the solid waste will be made into feces. So the bacteria that we have, some people call it microflora. It's really good because it means that it doesn't harm us, but they are helping us. So what they're called, or the relationship between us and the bacteria, is what is called mutualistic, meaning that it's beneficial for both. For us, they help us to create vitamins, and for them, obviously, to continue living because they're using our colon. And because it's in this enclosed environment, most of the bacteria is anaerobic, so they don't need oxygen for their metabolism. The infant receives the initial bacteria colonization from the mother during birth. And I don't know if you know, but there's been some feces implantation treatment. So for some people that have issues with their microflora or their bacterial population in the intestines, they have some results, good results, with having fecal transplantation. So small amounts of fecal matter from somebody that has that good bacteria into the colon of people that are having issues with their bacteria. Because if you don't have a good bacteria, you can lead to some diseases like diarrhea. That will be the most common one. But the other one is irritable bowel syndrome. And that is when you have bouts of constipation and diarrhea. So that will be very, very detrimental. And the defecation, I already explained how it happens because of the two different anal sphincters. And the defecation occurs by the relaxation of the anal sphincter, and obviously helped by the abdominal and pelvic skeletal muscles. So now we're going to talk about the liver. And again, the liver is not a participant in digestion, but it's an accessory organ, which is extremely important. The liver has so many different functions, right? But in the digestive system, well, one of the functions is to metabolize medicine, metabolize alcohol, It stores glycogen, it produces bile, it produces albumin. So we have, it has so many, and it also is a detoxifying organ, right? So it metabolizes anything that we put in our body, like medicine or alcohol and things like that. But in digestion, the liver's function is mostly to make or produce bile. So when we look at the liver, and this is a picture of the microscopic structure, these little cells that look like they're square, but they're really hexagons. These are the hepatocytes. And the hepatocytes are the ones that make bile. Then bile is collected in these green little ductules are called. And then all the ductules are gonna end up in this bile ductal. So this bile ductal is always together with the renal artery, hepatic artery, and also with the branch of the portal vein. So when you see the liver, you will have several areas at each of these points of the hepatic region here. You'll have what is called the triad. You have a branch of the portal, a branch of the hepatic artery, and a bile duct. And so that's what is called the portal triad. So when we studied the pituitary, we mentioned that we had a hypophyseal pituitary portal system. I don't know if you remember that, but a portal system is the one that goes from venules, tissue, veins, right? So we don't have the typical capillary bed that starts with artery, tissues, veins. Remember that? When we studied cardiovascular, we learn about our typical capillary bed, which starts with arteries, they branch out, we get the tissues, and then on the other end, we have the venules and the veins, right? That's the typical capillary bed. A portal system is when we start with veins, tissues, veins. So it's a little different, right? We only have two in our body. We have one in the pituitary, between the pituitary and the hypothalamus, and the other one is in the liver. So what we're gonna learn is how we're gonna absorb the nutrients via the hepatic portal system.
I have a question.
Yes.
What role does the gallbladder play with the bile, and what happens when they remove it?
The gallbladder, and let me show you this picture. The gallbladder is just a container, a reservoir of bile, right? The liver is the one that makes all the bile. All the hepatocytes make the bile. So all the bile is collected into the gallbladder. When we eat, and this is the small intestine, when in the lumen of the small intestine, we have a lot of fat content, means that you had a double bacon cheeseburger, for example. That's a trigger for the gallbladder to contract and send a bunch of bile into the lumen of the small intestine. When we don't have the gallbladder, because some people overproduce bile, and bile is made out of cholesterol and bile salts, which if you overproduce, these bile salts can crystallize and they start to clump up, and they may be blocking this bile duct. So if that happens and the gallstones are large enough, what they do is just they remove the gallbladder, they just cut it out here. And now what's gonna happen is that the liver continues to make bile, and bile is gonna start trickling down all the time into the small intestine. So people that don't have a gallbladder should not be having a double bacon cheeseburger, because it's a bunch of fat and they don't have that surge of bile when all that fat is present. So they may have issues digesting that fat faster than people that have the gallbladder. So if you have gallbladder surgery, it means that you have to watch it. It doesn't mean that you cannot eat any fats, but not overload the small intestine with so much fat that you're not going to have enough bile to start the digestion. Because we're going to see how bile help us with the digestion, right? But I wanted to show you I have a video on the portal system, but I have a little handout that I posted. Wait, that's not it. I have to go to, it's posted on this module, and I want to show you here. So I think it's on module, the module of digestion is my outline of the hepatic portal system, because it's very interesting how we absorb food. So far we said that we absorb food into blood, right? That is clear. We absorb it into blood. And we also said that we absorb, yes, question? And also I mentioned that we absorb fats into the lymphatic, right? But how do we absorb food into blood is through the hepatic portal system. So let me share this, and you have this posted, okay? Come on. Come on. Why can I share this? Okay, can you see it? Yeah? Okay, so this is my outline, and I know it looks daunting when you first look at it, but we start somewhere. And since we're doing digestive system, we're gonna start in the hepatic portal system. Remember what a portal system is veins, tissues, veins, right? So when we say that we are absorbing food directly into blood, this is how we absorb carbohydrates, proteins, and nucleotides, right? So in the small intestine, remember, we have the mesentery that I show you, which is that sheet of tissue with a lot of blood vessels, right? Now the blue capillaries in that mesentery that is holding all the small intestines, those are called mesenteric veins. So the food from the lumen of the small intestine is absorbed into mesenteric veins. The mesenteric veins, then they get all together and they send all that through the hepatic portal vein. Now the hepatic portal vein sends all our nutrients to the capillary bed in the liver, the tissues. Now the liver there manages where our nutrients go. So if there's a bunch of glucose, the liver may take some and it may store it as glycogen. If there's a bunch of amino acids, the liver may take some and use it to make albumin, okay? But the rest of all those nutrients, they're gonna leave the liver through the hepatic vein. So that's why we say that this is the hepatic portal vein, because we have vein, capillary, veins, right? It's very different than our regular capillary bed. And hepatic vein, like all the veins in our body, they drain into the inferior and superior vena cava, right? In this case will be inferior because the liver is below. So all those nutrients now are in our venous blood going into the inferior vena cava. Now, if you know, inferior vena cava along with superior drain into the right atrium, then they go into the right ventricle, and then it goes to the pulmonary trunk, and then it goes to the pulmonary arteries, then they go to the lungs to get the oxygen and get rid of carbon dioxide, then through pulmonary veins, and they come back to the left atrium, which goes into the left ventricle, finally getting to the aorta. And here in the aorta is where we have the nutrients that came from down here and the oxygen that came from our lungs. And then and only then the aorta can send everything to the body, and we have our little capillary bed in our tissues. And remember what we're doing. We give everything they need. We pick up everything we don't need, and we start going all over again. So when I first learned this, I was surprised as a student, because when we learn about cardiovascular, we say the aorta has the oxygen and the nutrients to take to our tissues, right? When we pump it out with the left ventricle, that's when we send oxygenated blood and nutrients. But look what the nutrients need to do first. They have to go through the whole venous circulation, get into the heart, go into the lungs, and then come back and join the oxygen, and then we can take it to the tissues. I was really surprised about that one. Okay, and then in this little outline that I did, I kind of like put all the systems and how they're all related, right? So we started here with our digestive system, right? But then when we talk about the heart and all this circulation, here is your cardiovascular system. Then we take blood to the lungs to reoxygenate. So this is your respiratory system. Then we send everything to our tissues. And then we have here our waste pickup. And what do? The soluble waste is our urinary system. The solid waste is our digestive system. And then in between, we have these other systems that, of course, lymphatic is the one that help us with picking up extra interstitial fluid and help us absorb the fat, which we're gonna see. And then we have our endocrine system, which we have everywhere, all the hormones helping us, right? And our immune system that, again, is kind of like wide distributed in the body, helping us to be away from danger and help us fight infections. So this little outline is kind of like the relationship between all the systems and how we absorb our nutrients. So this is posted on that module, okay? So you can review it whenever you want there. And where is my, no, don't tell me I close it. No, it's there. So let's, oh geez, why I don't have it? Is it this one? No. Oh, show all windows, yes. There we go. All right, so going back to hepatic portal system, remember it's the unique pattern of capillaries of veins, capillaries, veins, which is very different than our regular capillary bed in the cardiovascular system. So when you look at this picture now, you understand a little bit more how we absorb foods, right? So when we have a content of fat in the lumen of the small intestine, we're going to get bile secreted into there. And with the enzymes, we're going to finish up digestion right here in the small intestine. Then through the mesenteric veins, which are these three little blue ones here, which are on the mesentery, right, membrane-like, we're going to absorb the nutrients and we're going to take it to the hepatic portal vein. And then the liver, major manager of our body, is going to decide what to do with a bunch of nutrients, and whatever doesn't need is going to exit the liver through the hepatic vein. And that's where we continue on the route with the venous return, the heart, the lungs, and then we join the oxygen with all these nutrients to distribute to the rest of the body. Isn't that crazy how we do this? All right, so bile is what gives the color to our feces and our urine. And here in the small intestine, bile is metabolized by bacteria into bilirubin and urobilinogen. And that's what causes the color of our feces. And the same when we, what was that? And the same when we absorb the contents of these nutrients, we also are absorbing some of that bile, which is going to get into general circulation and it's going to become the urobilinogen in urine, which gives the color. You know what happens? That's something that I did here. All right. So how is it that a bile help us break down fat? So bile, let's see if I can do this because it's easier for me to do this. Let's see. Bile is going to be, I'm going to make fat yellow. So when you have a big piece of fat, let's say you ate lard. That doesn't sound that appealing, but let's say you took a bite of lard and you don't have bile, then you're going to use your lipase. And this enzyme is going to try to break down this fat, but because it's a big chunk of fat, it may only act on the outside of that chunk of lard, right? So it's not very efficient. But when you have bile, bile is going to break this bunch of fat into tiny, tiny little pieces. So now the lipase has a lot more surface area to go around every single little piece. And that's what is called micelles, which is what you have here. So what happens with bile is that it will cut up the big piece of fat, making it into tiny, tiny micelles or tiny pieces or droplets of fat. And so now the enzyme or the lipases are able to go around each of those and you can digest it very fast or easier. So now with the question that Ricky asked me, what happens with somebody that doesn't have a gallbladder? Well, think about not having that amount of bile, having very little bile because it's just trickling from the liver, then that piece of lard is going to take forever to digest. And if you ate that double bacon cheeseburger, you may feel really, really full for a while because not having that surge of bile from the gallbladder is not going to allow for those micelles to form, and the lipase is going to take longer to be able to break it down. So what the bile does is emulsification of the fat, which means breaking it apart into little pieces or micelles. So now we get to, in the 7 minutes that we have, we get to the pancreas. So pancreas is another accessory organ. You can see where the pancreas is located. Pancreas is a exocrine and an endocrine gland, right? We learned endocrine gland when we studied insulin, glucagon, somatostatin, right? But most of this organ has the exocrine function, which is from the acinar cells, they're called. So the cells that are not in the pancreatic islets, they are the ones that are making pancreatic juice. And all this juice is drained into the duodenum through the pancreatic duct. So you can see here in this picture how the duodenum gets the bile from the gallbladder or directly from the liver, and it gets the pancreatic juice. So these two are going to help finish up digestion, right? So bile, mostly with the emulsification pancreatic juice has the rest of all the enzymes that we need. And this is what happens when you have gallstones. So these are a lot of gallstones. And what happens with the gallstones is that they can block the ducts. And that causes severe pain. In the case of this picture here, this example, there's no way that these gallstones can disappear on their own. There's sometimes laser therapy that they can do when the gallstones are not that big, and they can kind of like pulverize them. Also, ultrasound will pulverize them into tiny, so it could create fine powder. But this example here, there's no way you can fix it. This one requires the surgery, gallbladder surgery, and the patient will not have that surge of bile whenever they eat fat. You probably are familiar with this picture of the pancreas, right? You see the lighter region is the endocrine portion, and the rest, which is most of the pancreas, is the exocrine portion. So you can see how the exocrine portion right here makes a lot of inactive enzymes that are called zymogens. Remember, in the stomach, we say pepsinogen. So anything that ends in ogen is inactive. And then when they get the proper pH, they become active. So in the case of pepsin, pepsinogen is inactive, but with the help of acidic pH, it becomes pepsin. In the pancreas, we have a lot of inactive enzymes, but because the pancreas also secretes bicarbonate, that changes the pH, and the enzymes then become active once they get into the duodenum. And unfortunately, you have to learn these enzymes in this little table because these are all the enzymes in the pancreas that we need to finish up digestion, to complete our digestion, along with our brush border enzymes, right? So in the middle column here, the second column to the right, you have the inactive form, which is the zymogen. So you see trypsinogen, it becomes trypsin. I don't care if you remember the activator, just the name of the enzyme and what it does. So trypsin is gonna break down peptide bonds. So this one is gonna help us with proteins. Chymotrypsin, same thing, peptide bonds. Elastase, also protein, peptide bonds. Carboxypeptidase, amino acids. Just learn that, don't learn all the carboxyl terminal. Phospholipase, phospholipids. Lipase, pancreatic lipase is the one that is going to help us finish up the digestion of fats. Pancreatic amylase, finishing up the carbohydrates. Remember that we started in the mouth, but then we don't do anything with the carbohydrates until we get this pancreatic juice. All these form the pancreatic juice. Cholesterol sterase, the name tells you what it does. It breaks down cholesterol, right? Ribonuclease has to do with breaking down RNA. Deoxyribonuclease, breaking down DNA, right? When we ate the DNA and the RNA of the plant, the cow, the fish, the duck, anything. Oh, I don't eat duck. I just saw ducks yesterday hiking, and that's why ducks came to my mind. But I don't really eat duck or rabbit. Oh, I see those when we're hiking, and I feel so bad for them. All right. I think I'm gonna stop here because now we're gonna get into the enteric brain. We have a brain, but we also have an enteric brain, a brain in our digestive system. You know, when you get nervous and sometimes you get diarrhea, that's it, that's your enteric brain. Some people say that the enteric brain is more important than the actual brain. I don't know if given that much information, but that's what they say. There's specialists that only study the enteric brain. Okay, so we're gonna stop there. I think we did good. We're almost done with digestive, and then Boy, next week is your exam? Yes. Oh, Julie was, yeah, I just realized that. When I said that, I'm like, oh my gosh. Okay, so exam number 4 is 15, 16, 17. Oh, thank goodness I finished 17 today. All right, so, and let me just look it up and see where is the labs that are going to be involved. Modules. Okay. So 15, of course, I know that we did ELISA. So that one is going to be as a lab. I'm going to list them anyway on an announcement, but just in case. So ELISA, and then the 2 respiratory ones for chapter 16. And then for chapter 17, it will be urinalysis. So they're not that many. That's pretty good. So ELISA, 2 respiratories, and urinalysis for labs. And then for lecture is 15, 16, 17.